to act as a chair in this focused symposium. I'm coming from Finland, from Oulu. I work there at the Verb Research Center at the Department of Physiology. And I have been working over 10 years, much more or less related to cardiovascular autonomic regulation and its relations to physical activity, or let's say also, of course, physical inactivity in healthy patients and cardiac patients as well. So I would shortly like to remind you, we have some rules which has meant for us by organizing committee, and the first one is that you should keep your mobile phones switched off, and also videotaping or photos are not allowed during this session. Today we have 4 presentations. After each of them we have time for some questions, and for that purpose we have here floor microphones. And before you ask, please introduce yourself and tell where you are coming from. But before we go to the presentations, it's my pleasure very briefly to make some introduction to this our topic. And when we put these things to, when we trying to get them a real perspective, this figure shows very nicely that if you think about main killer in the world, it really is cardiovascular diseases. So about 30% is related to cardiovascular diseases. So we can very easily conclude that prevention, treatment, and of course rehabilitation is chronic. Is a vital investment, of course. If you think about cardiac rehabilitation, it's very well documented that patients who are participating to cardiac rehab programs, they are gaining a better quality of life, and also we know that cardiac rehabilitation programs are cost effective, so it's very well justified, this cardiac rehabilitation. Here you can see the core of cardiac rehabilitation components, and I would like to emphasize that just the latest position stance, which is coming from European Society of Cardiology, they tell us in that position that physical activity counseling and exercise training may be the key components under which you can build up the other things we can see in this slide. We have 3 phases of cardiac rehabilitation. Phase 1 in-hospital program, and I know, and I'm quite sure that you are also aware that this phase during these days it can be really fast. Let's say it can be a couple of days when the patients they are returning back home from the hospital. Phase 2, which means early post-discharge program, it's usually 2 to 16 weeks after discharge. And probably the main target during phase 2 is to make life or motivate or promote lifestyle changes, and then we can go to the phase 3, which means a lifetime project basically. But let's go on. Our first speaker today is going to be Dr. Fernhall, he's a professor of kinesiology and community health and former associate dean for research and academic affairs in College of Applied Health Sciences at the University of Illinois at Urbana-Champaign in the USA. He's a director of the Exercise and Cardiovascular Research Laboratory and previously directed cardiac rehabilitation programs for over 20 years. So, please, Pooh.
Thank you very much. I want to thank Dr. Hautala and WCPT for inviting me to do this talk. And I hope to spend the next 20 minutes giving you a world tour of wonderful world of arterial function. So, just to give you a little brief introduction in terms of how we measure arterial function, and there are three main measurements that most people probably agree on, and that is, at least non-invasively, intima media thickness, endothelial function. There are various ways to measure those. Two that are pretty non-invasive, and then a more invasive one with response to pharmaceuticals, and then, of course, arterial compliance and stiffness. And I'm going to give you a quick overview. IMT these days is usually measured with ultrasound. We get an image typically of the carotid artery like this. And the space that we're measuring, intima medial thickness, is a very small space between the media and the intima on both sides of the artery. It's a very intricate measurement, and as you can see from these measurements here, we're really talking about a space that's less than 1 millimeter thick. Endothelial function is typically measured with brachial artery FMD, which means that we put a blood pressure cuff on the arm, inflate it for 5 minutes, leave it inflated, and then measure the response of the artery via ultrasound and direct visualization. Here's the brachial artery. We identify the borders, and then we plot how the artery dilates after the cuff has been released. We can also measure this with plethysmography, which is shown here, with the forearm strain gauge, and then we measure blood flow into the forearm, where both peak flow and the area under the curve are measured. All of these measures of reactor hyperemia are very valid and considered good measures of endothelial function. Arterial stiffness, the most common measurement is pulse wave velocity, which is, as you can see here, at various points in the body. We put a pressure transducer on the pulse. We generate a pulse curve. We put it on another segment in a different portion. We then measure the time delay for the pulse to get from here to here. And it's very easy to figure out what's going on by knowing this time delay and the distance from here to here. We can calculate the velocity. The higher the pulse wave velocity, the greater the arterial stiffness. So, why do we do this? Well, as you can see from this particular slide, IMT is very much related to outcome. So these are events per 1,000 person years. And you can see that as your IMT goes up, so does the events. And if you really want to have problems, you want a large IMT and you want to be older. If you want to have a very small amount of problems, you're young with not much of an IMT. So as we grow older, as you can see, what happens is our IMT also grows older. So some of these problems with arterial changes are related to age and not just disease. Endothelial function has been long recognized as being something that we can measure early before we get histological or angiographic evidence of disease. But the best part is that FMD is actually predictive of clinical outcome. So here are two examples of that. In this is a healthy cohort, and as you can see, as FMD is above the median, this healthy cohort does quite well. But if FMD is below the median, this healthy cohort does much more poorly. The same is true in a variety of people with heart disease or various forms of heart disease. In this instance, somebody that has coronary stent implementation, and you can see the composite endpoints. High FMD survival is very good. Lower FMD survival is poor. And even in-stent stenosis is predicted by poor FMD versus high FMD. Maybe the most important thing is a number of studies have now been shown that if FMD changes, that change is also predictive of outcome. So endothelial function that is improved, outcomes are very good. If it's persistently impaired, outcome is much worse. And this particular study is in chronic heart failure patients. So, and why is arterial stiffness important? This is a slide of a recent meta-analysis, and what you can see here is in total cardiovascular events, cardiovascular mortality, and all-cause mortality, that the overall risk is about double in those individuals for all three causes if you have stiff arteries. So arterial stiffness is also very clinically important. That was just to give you an introduction on what we look at, what we measure, and why we do that. Now I'm going to talk a little bit more about what's the effect of cardiac rehab on these various measures, but we don't always have cardiac rehab specific information, so some of this will be physical fitness and physical activity oriented. In this particular study, physical fitness was measured through VO2 max down here, and you can see that those with high VO2 max, both mean IMT and max IMT, is much lower than in those that are less fit. So less fit is associated with higher IMT, therefore higher risk. This is a study out of Finland, and it's a fairly good-sized sample. But more importantly, the increase in IMT, the 4-year increase, is also related to fitness. So in the high-fit people, this increase is much less than in the low-fit people. The same thing is pretty much true in people that have a lot of risk factors. So in high-risk populations, and this particular example is a study of hypertensive men that did not have recognized heart disease or arterial disease per se. And what you can see here is, again, high-fit individuals, much less incidence of high IMT or carotid atherosclerosis. Low-fit, much, much higher incidence, close to double the incidence. In a fairly recent study, we got some very promising information that actually suggests that if you just walk 4.2 kilometers per day, this is associated with a significantly reduced progression of carotid IMT, which is very significant because as that IMT progresses, the risk of more serious events go up. So very encouraging study, and 4.2 kilometers per day is certainly a distance that can be easily handled by most patients in our cardiac rehabilitation programs. So we know that fitness and physical activity are both related to reduced IMT and progression of IMT. But the direct effect of cardiac rehab per se on IMT hasn't really been studied to date. So, what's the effect on endothelial function? This is one of the earlier studies on this from Germany, from Dr. Hambert's lab, and this is one of the what I would consider sort of landmark studies in this area, showing actually that in the exercise training group, the response to acetylcholine, which causes vasodilatation, is significantly enhanced after 4 weeks of exercise training. And it doesn't matter what dose of acetylcholine was used, we see about a doubling in the vasodilatory response. This did not occur at all in the control group. And nitroglycerin had no effect. There was no effect of training on the response to nitroglycerin, suggesting that it's just the endothelium that's affected by training and not the smooth muscle per se. They were further went on and actually were able to obtain arterial samples and were able to show that the reason the endothelium improved is essentially endothelial nitric oxide synthase availability following training. So a number of ways of looking at ENOS expression, but basically showing that nitric oxide metabolism is the primary explanation of the improved endothelial function, at least in this sample of patients. This is a follow-up study by a different group, and what they were able to show is essentially the same thing, but now using non-invasive measure of brachial FMD, showing that in a control group there is no change, but in the exercise group there's a very nice enhancement of FMD. This is by looking at blood markers of nitric oxide metabolism. We get to the same mechanism as Dr. Hamburg's group, and that mechanism is probably related to a decrease in antioxidant capabilities, because 8-isoprostane is a measure of antioxidant. The other thing is the total antioxidant protection is improved. So the ability to protect the body against oxidative stress is important, and that is likely then related to the improvement in nitric oxide metabolism, leading to enhanced FMD of vasodilatory capabilities. There's been some suggestion in the literature that high-intensity exercise may actually be damaging, and there is some evidence, particularly from resistance exercise, that may be the case. However, when we look at this in a standard cardiac rehabilitation group, this is data out of Norway from Dr. Wislof's group, we can see here's the control group, a moderate exercise group, and a high-intensity interval training group. And as you can see, FMD here is more improved to a much greater extent with high-intensity exercise than moderate-intensity exercise. But both improves endothelial function while there is no change in the control group. We see a similar response in VO2 max, suggesting that these improvements in endothelial function might be related to improvements in fitness. What happens if we include resistance training? This is a very important point because we often use resistance training in cardiac rehabilitation. And in this 8-week combined study, typical exercise program used in both aerobic and resistance training in patients, in post-MI patients, what we can see is in the untrained condition, individuals with coronary artery disease has very low endothelial function. They also actually have low function of the smooth muscle. But when we train these individuals, they improve their endothelial function, and they actually improve it so much that they're now very similar to the untrained controls that did not have heart disease. So this is a tremendous improvement, and as you can hopefully remember from a few slides ago, improvement in FMD is related to outcome, particularly in patients that have heart disease. I like this study a lot. This is fairly recent, and one of the reasons I like it a lot is that the N's are very large in each group. So, group 1 here, aerobic training. Here's resistance training. There's a combined aerobic and resistance training and a control group over here. What you can see is regardless of the form of training used, there's a great deal of improvement in FMD or endothelial function. That's then followed by detraining. That improvement disappears, whereas the control group doesn't change at all. And this occurs after only 4 weeks of training. So, I think we can easily make the statement that exercise-based cardiac rehabilitation improves endothelial function, regardless of exercise intensity and exercise mode. High-intensity training appears to be more effective than the standard moderate-intensity training that we typically use. So, what's the effect of exercise and cardiac rehab on arterial stiffness? it appears to be a little bit less clear than what we've seen with IMT and with endothelial function. When we're looking here, this is augmentation index, which is not really a true stiffness measure, but there was an improvement. The reduction is an improvement following the exercise training. The time delay from the augmentation index was increased. Increased time delay would suggest improvement. However, in this particular study, the group that trained at a lower intensity did not improve fitness and also did not, these are the darker bars, also did not change arterial stiffness, whereas the group that trained at higher intensity level showed a nice decrease. However, in this particular study, the group that trained at a lower intensity did not improve fitness and also did not, these are the darker bars, also did not change arterial stiffness, whereas the group that trained at higher intensity level showed a nice decrease in pulse wave velocity and a nice decrease in arterial stiffness. In general, well over 40 studies have looked at this in a variety of populations, and almost all of them have found a decrease in arterial stiffness with standard endurance training. But there's been some argument about what's going on with resistance training. We noticed this a few years ago where we actually saw an increase in arterial stiffness with training in a hypertensive population. This would obviously not be a good effect. However, a low-intensity training program that is typically used in cardiac rehabilitation actually shows a decrease in arterial stiffness and a simultaneous increase in FMD, suggesting that the type of program that we typically use in cardiac rehabilitation is very effective in improving arterial function. So, pure resistance training, if you want to call it that, at a much higher intensity level, may increase arterial stiffness in some population, but in general, the lower intensity training programs that are used in cardiac rehabilitation, specifically when they're coupled with aerobic training, yield generally very nice effects and a decrease in arterial stiffness. The last thing I wanted to just mention is something that might happen that we have seen very little data on, and that's plaque regression. Ultimately, in cardiac rehabilitation, we would like to see the plaque disappear in our patients, but that's not something that we typically see. This is a study from a long time ago and still one of the few studies out there that actually have shown something, where plaque regression was shown. And there is actually a decrease in stenosis in the artery of those individuals that were the most adherent to the program. The problem here is that this program is very unique. Purely vegetarian diet, no fat allowed, no sugar, no salt, stress management, exercise training, and social support. This has become known as the Ornish program in the U.S., and in general, it's been very effective. The problem is it's very difficult to stay with. But this is the only program that have been able to consistently show plaque regression, at least to my knowledge. This was a follow-up of these same patients 5 years later. And what you can see is in the experimental group, only 1% actually got worse. 99% was better or no change in plaque. Whereas in the control group, 45% of the patients show plaque progression. So, overall, I think we can state that endurance training-based cardiac rehabilitation programs improve arterial function, especially in populations with reduced arterial function to start with. Resistance training may increase or have no effect on arterial stiffness, but does not appear to increase but does appear to increase endothelial function. And the types of programs that we typically use for resistance training in cardiac rehab patients appear to be beneficial. Standard cardiac rehabilitation, although I didn't show you data on this, has no effect on plaque regression. But very intensive multifactorial programs may have a beneficial effect. So I want to finish up by thanking all the people that have been working with me over the years on various studies and some of the funding that has been involved. Thank you very much.
Thank you very much, Bo, for your very clear presentation. We have time for a couple of questions from the audience. Please. Okay, may I ask you, Bo, it seems that high-intensity training, or let's say interval training, it has quite a good potential. Can you make some comment on safety issues or safety aspects related to this?
Well, the type of high-intensity intervals that are used are a little bit different. They're called high-intensity aerobic intervals. They're intervals that are below VO2 max. So what athletes typically use in interval training are intervals that are above VO2 max, and that's a big difference. So the types of intervals that have been used in cardiac rehab appear to be quite safe. There's never been any safety issues reported. In fact, there's some early data suggesting that they might be safer than the standard moderate exercise intensity programs.
Yeah, thank you. Yes, please.
Hello, my name is Gilgen Hans-Peter. I come from Switzerland. I've got a question about the intensity. How do you actually calculate the heart rate when you train with the because they have a lot of medicaments and the variability of the patient is quite it's difficult to have do you calculate the heart rate according to the ECGs after the they had a heart attack, or do you more use Berg scales, or how do you
the intensity is usually based on heart rate. So typically it depends a little bit on how it can be done in a little bit different ways, but in general it's based on the heart rate from their maximal exercise test. Mm-hmm. So we know their maximal heart rate and can then calculate intensity based on that. Sometimes that's also related then to their VO2 max to ensure that the stimulus is high enough. But it's always an intensity that is less than maximal heart rate.
Yeah. Because we made a bit, sometimes we had problems to really get the real maximal heart rate after they had an attack. Sometimes when they're on a bicycle, they have to stop before they have the maximal because they're not used to exercise or so. And
it depends, I guess, on what you mean by maximum heart rate. If you're using the formula 220 minus age as a guide for maximal heart rate, you need to stop doing that immediately. It doesn't work in cardiac patients, so you can't use it. The maximal heart rate that you should use should be the one that's from their own maximal exercise test. So in heart patients, it's very likely that that's going to be substantially less than whatever you come up as a prediction using the standard formulas. So therefore, formulas should never be used in this population.
Yes. And how often, last question, how often do you...
I'm sorry, maybe we continue discussions later. Okay, thank you. Let me then introduce you our second speaker, who is going to be Dr. Tetsuya Takahashi. He is a professor of physiotherapy at the Tokyo University of Technology in Japan. He has worked over 20 years in the field of cardiac rehabilitation, focusing, for example, resistance training and prevention of muscle disuse for patients with cardiac diseases. His topic today is going to be resistance exercise training for patients with coronary heart failure. Dr. Takahashi, please.
Okay, thank you, Arto, and good afternoon, everyone. This is a great opportunity. I like to share my experience about resistance exercise training for patients with heart failure. Now we had quite clear evidence. Dr. Wu told us about resistance exercise training also, but I'd like to talk about a little bit issue we are facing. From Japan, the East and rising some country, the Asian country facing high aging society, and also I'd like to talk a little bit about a few concepts of a new idea of resistance training for their safety and effectiveness. And first of all, I'd like to share what's going on in Japan about exercise training. Because, as you all know, aerobic exercise training, like a bike exercise, a treadmill exercise, is very key and like a typical exercise type for the patient with heart disease. Then, like a fitness exercise, like a stretch exercise and warming up exercise too. But until late 1990, this kind of resistance exercise has been considered as quite inappropriate. It's not appropriate for the patient with heart disease because these pressure load on the heart may accelerate their left ventricular remodeling. So, like 20 years ago, we really don't want to do the resistance exercise with heart failure or patient with heart disease. But this movie is come from the Saitama Medical School. Even in Japan, there are several facilities is positively installed resistance training, even if they have quite severe heart disease. All these patients has left ventricular assisted devices, as you can see it on the slide, like portable devices. Even they are very severe heart failure. We prefer to do resistance exercise now. So there are several guidelines already have been published already and revised every day, and American Association and European Association too. And also, Japan as a circulatory society also has published exercise guideline, including resistance training, and revised 2007, and now is revising until 2012. So, as we have same discussion last presentation, intensity of exercise always is at the center of the discussion. According to the guideline, the initial intensity for the resistance training for patients with heart disease it will be 30 to 40% of one repetition maximum for upper body, and 50 to 60% of one repetition maximum for the lower limbs, and then increase progressively up to 80% of one repetition maximum is quite high. And frequency 3 times a week, and 10 to 15 repetition and 2 to 3 set. This is a kind of typical guideline for resistance training. So these are also from guideline. We have to select this type of exercise, which is measure muscle group of the upper and the lower limb exercise. But it seems to be good for the younger generation, younger population, younger patients with heart disease, to do resistance training with 50 to 80% repetition maximum, and 2 times a week, so 2 to 3 months is going to be fine. But all over the world, we are now facing a quite serious issue, aging society. So we have so many patients older than 75 or 80 years old. So those patients need to pay special attention. So as you can see easily here, of course, Japan is now 23% of population is more than 65 years old age. So we call this a super aging society. But not only Japan, in the United States also, and in Western country too. Now you rapidly increase number of the population of the more than 65 years old. And also in Japan, heart failure is one of the most common reasons for hospitalization, hospital admission. There are 2 million patients in heart failure, and number of heart failure increase due to lifestyle will be westernized, and also we have so much patients with elderly patients. To the elderly patient, it's really hard to do. But muscle strength, muscle mass, and muscle power is very important for their life, active life. But it's really hard to do resistance training at the 50 to 80% demanded position maximum because of they have usually orthopedic and joint problem, and also hemodynamic and arterial stiffness issue, also metabolic issue must be taken in consideration to do resistance exercise. We usually prefer to do decrease intensity then, but I really consider about low intensity is really effective. Look at this movie. It's a typical Japanese lady doing resistance exercise with very light weight and very fast movement. I don't think this is really effective, but this is I should say it's really typical. I can see many places in the elderly facility. As you know, the muscle strength, muscle mass is really important to overcome frailty or to get independent life, active life. But I'm not talking about today is this physical activity and nutrition status and hormone status. I really want to talk about today is more chemical or metabolic stress during resistance training, because we can't force them so much stress. So then we select low intensity resistance exercise, but really little slow movement with slow movement. For example, 3 second lifting and 3 second down. So look at this movie. So upside of the movie, the lady doing low resistance exercise, resistance exercise with low intensity and fast movement, but lower lady doing low intensity with low or slow movement. And next gentleman also, he performed knee extension exercise with low intensity, but upside movie is really fast, but lower side is quite slow. Why I mentioned about slow movement? If we do look at this figure, because this is a study from University of Tokyo. They compare 3 types of exercise. One is low intensity with slow movement. One is high intensity in the normal speed, like a 1 second lift, 1 second down. And this C shows low intensity exercise with normal speed, like 1 second up and 1 second down. But if we do low intensity and slow movement, like 3 second up, lifting up, and 3 second lifting down, and continuously, so then relative oxygenation and the muscle oxygenation is decreased during low intensity with slow movement. It's quite similar response during resistance training with high intensity. So we don't need to do high intensity resistance if we do throw low resistance, low intensity with slow movement. Also, interestingly, the blood lactate concentration also increase similarly between low intensity slow movement and high intensity normal speed. So we can produce chemical stress on the muscle, even low intensity if we do slow movement. But as we all physiotherapists, we consider about resistance, exercise specificity. So if we do slow movement, only slow movement, patient can not move fast. So we, as a physiotherapist, we shouldn't only give them the resistance training on the machine. We prefer to more, once we have muscle strength, we do more like activity, exercise too. We prefer to do. Even though on the bedside, on the bed, she is quite a severe heart failure, like a New York Heart Association class 4. On the bed, we prefer to do resistance exercise, like simulated to the normal life, because she needs to, next stage, she needs to standing up. Last one, I want to share one of the Japanese idea or concept or the resistance training. This is a quite interesting trial. We call this is Atsu training. Ka means add-on, ADD. Atsu is a pressure. So it looks like interesting. This is performed by Dr. Nakajima at Tokyo University, my student over there now. So if the patient, look at this, and based on the limb, it's pressure applied by a special designed belt named as Kaatsu in Japanese. So we restrict blood flow a little bit, not stop the blood flow, we just restrict blood flow. I can say it's a venous return, we restrict the venous return, but not totally stop the blood flow. I can share the video here, movie here. This is myself. I do resistance exercise with TheraBand. It's quite lightweight, but look at my color of my forearm, and because of the blood restriction, so my forearm color is going to change. So even interestingly, if we do this kind of resistance exercise, low intensity resistance exercise with blood flow restriction, they makes quite a huge change. So this is Dr. Nakajima's data. If we do bilateral extension exercise with 20%, very low intensity of 1 repetition maximum with blood flow restriction at that time. So growth hormone and insulin-like growth factor 1, IGF-1 also, vascular endothelial growth factor quite, show very high value compared with resistance exercise without blood restriction. So this is quite interesting because we have a very severe and aging population with heart disease. So I don't want to put them so much higher intensity of resistance. So we don't need to higher resistance, but we do need a little bit blood restriction. And this type of exercises, they have a little patent, so I cannot tell you exactly what they are, but I'm sure this is going to be a very effective way, and it's going to be very, pay attention to that. So in conclusion of my presentation, ladies and gentlemen, resistance exercise training in patients with heart failure become or very much popular now. So several guidelines has been published, and but number of elderly people is increased. Elderly people with heart failure increased. Then we have to consider, we have to develop new concept of resistance exercise, such as resistance training with slow movement or resistance training of blood flow restriction. We also consider not only put on the machine but also we always consider simulated activity of daily living, because training always has training specificity. Thank you very much for your kind attention.
Thank you, Dr. Takahashi. It was a very nice overview of the resistance training related to cardiac patients, and very interesting new ideas. For example, this blood flow restriction method. It seems very interesting. We have time for some questions. Please.
My name is Hazel Dreyer. I'm from Boston, from the USA. We have a large heart failure clinic. Are you suggesting that we start using the blood flow restriction method when we do very low-level resistance training with almost all the patients, mostly hand weights and small leg weights, but I'm sort of a little afraid to try the blood restriction. Are you suggesting we should be going ahead and doing this right now?
No, no and yes. Dr. Nagajima told us now they're doing some research things, but there are not many evidence so far. But what I saw in his laboratory, in his department, really, he's just doing like a really small action, like for 30 seconds something, without any weight. Then they said, okay, yes, this is effective. So I'm not going to say this is going to be the more popular thing, this is gold standard, but for example, patient with really severe patient, one of the options we can choose this type of special type of exercise. Just what I want to say.
Yes, please go ahead.
Bill Brennan, Australia. Have you looked at the difference between concentric and eccentric exercise, and do you think there's any value in a specifically eccentric exercise program?
Yes, I agree that. I didn't focus on today, but for the mechanical stress, not chemical stress, we know the eccentric contraction, like more stretching exercise, stretching muscle is much more effective and produce more higher IGF-1 and higher growth hormone. So eccentric contraction is we have to do it more.
Okay, one more short question, please.
Dieter Steiner, Switzerland. What I would like to use this kind of cuffing as well for lower extremities? Do you use this kind of cuffing as well for lower extremities?
Sorry, I can't hear a little bit.
Do you use it just for arms or for legs as well?
Okay. We just use leg and arm. Leg and arm. Depend on where we want to change. So if we want to change leg, just add it on the legs.
Ladies and gentlemen, our third speaker today is going to be Dr. Mikko Tulppo. He is a professor of exercise physiology at the University of Oulu in Finland, and he is a director of Department of Exercise and Medical Physiology for research in Oulu, and his current research focus is the acute effects of exercise on autonomic regulation and chronic changes in autonomic nervous system after exercise intervention in healthy subjects and cardiac patients as well. Mikko's talk today will be related to physical activity among cardiac patients with and without type 2 diabetes. Mikko, please.
Mr. Chairman, ladies and gentlemen. Here we have a picture or figure which motivated us to study cardiac patients with and without type 2 diabetes. You can see here this is a survival curve. This is a Finnish study, and we have this red line. These are patients with myocardial infarction plus type 2 diabetes. And the yellow line, there are non-diabetic myocardial infarction patients. And you can see that there's a huge difference in surviving curve between diabetic and non-diabetic subjects. So in 8 years follow-up, almost 50% of the subjects died. This is our ongoing study, actually, which I'm going to look at now, and we are calling it Artemis. And in this study, we started this 4 years ago, and we are going to collect, or we are collecting 800 cardiac patients with diabetes and 800 without diabetes, and we are profiling these patients very carefully according to autonomic nervous system, echocardiography, Holter recordings, metabolic control, also genetic factors, and a lot of different kind of biochemical factors. So we are profiling these two kind of populations. However, we will take 200 subjects to the exercise training intervention, which is planning to last 2 years, actually. Here is this our exercise training intervention and we are aiming to have 100 without diabetes and 100 with diabetes subjects. And we are also measuring, of course, controls and a couple of healthy subjects, because we are using some novel technology to measure physical activity for these subjects. So we are measuring healthy subjects also. So we are measuring VO2 max, of course, metabolic control, autonomic nervous system in the beginning of the exercise intervention, after 6 months, after 1 year, and after 2 years. And of course we are doing the maximum VO2 max test, and we are tuning or tailoring to the exercise prescription for the subjects in every those measurement points. We are also measuring heart rate variability, which is a quite easy tool to look at the prognosis of the patients. So we are measuring actually every week short-term heart rate variability recordings for these subjects. It's meaning almost 20,000 heart rate variability files to do. And also we are measuring physical activity every month, 1 week. So, and of course we are looking at major endpoints. So the major endpoints is a combination of cardiac death and hospitalization of the patients. So the main question here is, can we improve the cardiac patients' prognosis by exercise intervention? At the moment we are standing in the middle of the study still, but I would like to share the very preliminary data with you today. So at the moment we have about 50 subjects in both groups, non-diabetic and diabetic patients. So this is our exercise prescription for those patients. So for first 3 months is quite easy exercise for these subjects, and from 4 to 6 months it's a little bit more harder. 4 times per week aerobic exercise and 1 time resistance exercise. Of course, after that we are still increasing the exercise training for these subjects. So aiming to have exercise training sessions every day, basically, at the end of the study. Okay, we are going to see the results about the physical activity between these two groups, but also I would like to share the dose-response relationship in between CAD and CAD plus type 2 diabetes patients. Here we have example about the physical activity data what we have from these patients. This is at the baseline. This is actually 41 years old healthy male, and we are using the accelerometer, which is able to measure physical activity time in 5 different categories: slow walking, walking, brisk walking, jogging, and running. So we can see this is a healthy male, and he's running daily 1 hour, and we can see very nicely that he has been really running daily basis 1 hour, and our equipment are able to pick up that training stimulus. This is another example. This is a 53 years old coronary patient, and we can see that slow walking, slow walking there's only 2 hours or plus, and walking only a couple of minutes, and no physical activity at all in higher intensities. Of course, our patients' physical activity or physical fitness is quite low. The maximum METs is less than 10, the average. So we put physical activity data not in 5 categories, but in 2 categories: slow walking and walking together, and brisk walking or higher activities together. This is data for without diabetes and without diabetes patients, and you can see that there's a clear difference between these subjects. So the type 2 diabetes patients are less physical active than CAD patients. And also we have a healthy subjects about 4.5 hours, the average of the healthy subjects, which is not shown here. This is a brisk walking or higher physical activity between those populations. Again, you can see that diabetic patients, they have a less high intensity physical activity than patients without type 2 diabetes. But when you look at the absolute minutes, what they are doing only 5 minutes brisk walking or higher at the baseline conditions, and type 2 diabetes patients only 2 minutes brisk walking or higher physical activity. So we are very far away from that 30 to 60 minutes where we are aiming to go. Okay, what happened after 6 months exercise prescription? You can see results here. This is without type 2 diabetes, and this is slow walking or walking activity intensity, and you can see that there's no increase in low intensity physical activity between in CAD patients or in type 2 diabetic patient groups. And also this type 2 diabetes patients, they are still slow walking or walking activity is still significantly less than CAD patients without type 2 diabetes. Okay, this is a little bit better picture, and here we have a high intensity or brisk walking or higher physical activity intensity after 6 months exercise prescription, and you can see that we were able to increase physical activity of these subjects almost double in both groups. Okay, in another topic, we have a look at the dose response in both groups, and we are talking about the training impulse versus VO2 max. So we have both these groups are sex, age, and ejection fraction matched populations. You can see here the results. And of course, body mass index is higher in type 2 diabetes patients. Here is the effects of the 6 months exercise prescription for the VO2 max. And you can see first at the baseline, type 2 diabetes patients, they have they are lower fitness level, but after the training, after 6 months training, both groups are benefiting very much similarly about the training session. So there's a very nice increase in VO2 max in both groups. However, here we have individual changes in VO2 max. One bar is representing one individual, and you can see that first there was no correlation between the change in VO2 max and baseline VO2 max. There was no correlation. Anyway, VO2 max increased nicely as a group, but in some subjects there's a huge increase in VO2 max, but in some subjects there's a very clear decreased VO2 max after 6 months. But of course most of the subjects are increasing. But there's quite many patients with VO2 max actually decrease during the 6 months prescription, exercise prescription. These are type 2 diabetes patients, and the picture, it looks very much similar. There's no correlation between baseline VO2 max and the change in VO2 max after 6 months. Again, the increase is significant, and again there's a couple of subjects who are benefiting very dramatically about the training, but there's some subjects whose VO2 max is actually decreasing. Of course, now we have to know how much these individuals have been doing training. That's the key issue here. So every subject in this study, they have a diary. We give them a diary, and they are writing down every exercise sessions, and they are using heart rate monitors, and we really know exactly what kind of training they have done and what was the heart rate during the every training sessions, and we can calculate so-called training impulse, which is here. So the exercise time, heart rate, and different parameters for men and women. So this is a very easy and well-known index of training impulse. Here's the individual training impulses during the last 3 months in this study. So you can see that there's a huge differences between different individuals, of course. This is the target. Our target training was about training impulse per week, about 200, but some subjects are doing almost 800, 900, which is more or less like an active athlete almost. And some subjects are not doing the training at all. So there's a huge differences between how the people are doing our prescription. Same picture for the type 2 diabetes patients. Again, you can see that some subjects are really doing very much training. Actually, this was a winter season, and these couple of patients were doing cross-country skiing a lot, more than 4 or 5 hours a day. So, and again, you can see that some patients are not doing exercise so much. So the question is now how the training impulse is correlated to the change in VO2 max. And this was a little bit surprise for us, actually. These are without diabetes patients, so the correlation is very low, actually. And you can see that the training impulse is increasing. There's a trend that the VO2 max is also increasing, but the trend is quite low. Here we have type 2 diabetes patients, and you can see that there's a trend and a little bit stronger correlation between training impulse and change in VO2 max. So this was actually also a surprise for us. Okay, the question is the type 2 diabetes modifying training response in these populations? Okay, this is again training impulse here and change in VO2 max here, and this is the both population now together. And in this model the correlation is 0.31 between training impulse and change in VO2 max, and there's a high correlation. And now we can put model 2, where we have a regression model where we can put the training impulse, type 2 diabetes, and also the interaction between training impulse and the type 2 diabetes to the model. So we can, this way we can mathematically or statistically look at is the type 2 diabetes modifying the training impulse. And again, training impulse and change in VO2 max correlation 0.29, but the type 2 diabetes is not modifying, it's not significantly correlated to the changes in VO2 max or the interaction between TRIMP and type 2 diabetes. Again, it's not correlated significantly to the training response. So, ladies and gentlemen, Mr. Chairman, my take-home message is that type 2 diabetes does not modify dose-response relationship in exercise training among cardiac patients, which is actually a good news that we can say to the type 2 diabetes patients that when you start to do exercise training, we can be quite sure that we can have a nice improvement in VO2 max. Thank you for your attention.
Okay, thank you very much, Mikko. Now some questions from the audience, please. I think that the really important message that in this kind of exercise interventions, you really can promote physical activity as was seen in these higher levels of physical activity. So I think that we can say that the intervention was successful in terms of PA promotion.
Yes, I think so, that the patients were they increased their VO2 max and they increased their long-term physical activity also. And of course, the key question will be: are we able to decrease the cardiac events or hospitalization with exercise training among these patient populations? That will be seen after a couple of years, maybe.
Yes. More questions? Okay, thank you, Mikko. We go on. And our fourth speaker today is going to be Dr. Sumio Yamada. He is a professor of physiotherapy, School of Health Sciences at Nagoya University in Japan, and he is the director of the Center for Elderly Fitness and Secondary Prevention Research. And Dr. Yamada's research interests include the role of exercise in patients with congestive heart failure, as well as exercise-based lifestyle change in cardiac patients. And his topic today is going to be functional limitations, a treatment target in physical therapy practice, may predict the prognosis in patients with chronic heart failure. From the findings of the PT MATCH trial, Sumio, please.
Thank you very much for introducing Arto. My topics of today's talk is a bit different from the topics with the previous speakers. So my topic is I'm dealing with functional limitation. Functional limitation is pretty much familiar with physical therapy practice. Okay. So this is my scope of my talk. Is a functional limitations. What's the cause? What's causing chronic heart failure? And we developed to measure functional limitation in chronic heart failure. So I'd like to present our process of our research. And the last is a clinical validation of newly developed functional limitation measure, which is called PMA-8. We call it P8. So I present later. So functional limitation measure, it's a famous functional measure is New York Heart Association functional class, so-called NEHA class. NEHA class has four class from no limitation of physical activities, slight limitation, marked limitation, and unable to carry on any physical activity without symptoms. So the patient cannot leave from the bed. So, however, those evaluation of functional class by this simple NEHA questionnaire is precise evaluation or criteria of evaluation by this simple questionnaire is really depends on clinical experience. So, my idea is if we have, we need more objective and also patient self-report measure, which we do not need any clinical experience with. This slide shows cause of functional limitation in heart failure. So those are the adaptive mechanisms due to lower cardiac output due to heart failure. So heart failure induce renin-angiotensin aldosterone systems and activities of the sympathetic nervous system, sympathetic nervous activity system, the vascular resistance, low perfusions, maybe even kidney anemia through kidney dysfunction. Also in the catabolism or inflammation, which is cause for myopathy and excess ventilation, and also skeletal muscle loss. So those adaptive mechanisms is important things is those adaptive mechanism is progressive. So heart failure patient, heart failure is progressive disease, and functional limitation. My primary idea is functional limitation might reflect those progression of those factors. And if so, we could estimate the patient prognosis or patient safety for long life by evaluating some measure for functional limitations. And another feature of chronic heart failure is systemic disease. So systemic disease characterized by skeletal muscle dysfunction. In 1987, Dr. Coates is now probably a director of School of Medicine at Sydney University. This figure is not his original, and he proposed so-called muscle hypothesis. And muscle hypothesis means symptom of chronic heart failure may be determined by skeletal muscle dysfunction. So anyway, I'm showing it, simply the framework. If the heart damage is big enough, those organs begin to interact. Then, especially in skeletal muscle dysfunction, if those symptoms, let's say, it's shortness of breath. You might think shortness of breath maybe come from lung condition, but still, that hypothesis or mechanical reflex, the ergo reflex in skeletal muscle, sound directly to the center of brain, and then the brain activates ventilation, and then causes shortness of breath. And also, myopathy might cause fatigabilities. And also, those symptoms may cause depression. Depression may cause probably sleeplessness. So those symptoms of chronic heart failure is really systemic. So from now, I'm talking about our newly developed measures, a process of development of our new measure. So these are known advantages of self-report measures. So we call performance measure for activities of daily living aid. Daily living aid 8 means 8 items. So now I call it P8 instead of PM8. It's much more easy for me to pronounce. So this is scheme for process of developing P8. So first step, we just correct questionnaire items, the 448 from the 30 scale in rehabilitation programs from all the world. And then 40 original PM8 items, the mother items, was chosen by the panel of experts. Third step is 8 items was selected from the pilot study through a standardized process. Then the final step is the validity and viability of P8 were established in chronic heart failure patients. So from here to here, we made a P8. And then my talk, later my talk, progressive value of P8, and also a prognostic value of P8 also examines chronic heart failure patient in single hospitals. And also, I would like to show you our late-breaking results in multi-center study, cohort study. So this is the 40 items. We call them mother items. So, and then those 40 items, or these 8 items were selected by through standardization. So each items were we use in a 40 Leica. I'm not sure about Leica scale. It's a 5 or a 7 Leica scale as well. Sufficient for now, or maybe 4 items may not sufficient for patient self-report though. Anyway, we just hate the patient to put the meals. I don't know. Anyway, so it's each item has the 1, 2, 3, 4 grades. So for example, so vacuuming your rooms is very easy. Then we gave this the 1 point. So P8 score is range from 8. 8 means very good fit. To 32 points. 4 times 8 to equal 32 points. 32 points is a greater PA score, greater physical, and functional limitations. This is a result of logic measures fit statistics of P8. So it's item numbers here. So working and it's a logic measures. Logic measures usually it's good. The 1.0 in between the items. So logic measure is bigger logic measure. In this case, is very easy to perform. And then walking up slide for 10 minutes is hardest for our population in patient with chronic heart failure. So infit MSC infit means it's a level of fitness, level of fit. So goodness of fit range from 0.6 to 1.4. So we just from these this result we I think we successfully developed functional measure for patient with chronic heart failure. So what's about clinical validations? So first, it's now still under review. So it's not published yet. So the first, I just say we sought for the meaningful value of pH. So what score is meaningful for our estimation of prognosis or things like this. So aim is to explore the prognosis value of pH. This is study design, so method is study subject to we have the 72 patients. A patient who underwent cardiopulmonary exercise testing in our university hospitals. So patient etiologies, we have many DCM patients. It's maybe it's a future of our university hospitals. So I don't care the etiology of the patient. And measurement is just a questionnaire for pH and health score is depression scores. The physical assessment of the BMI, the cardiopulmonary testing, the VO2 and VCO2 slope from cardiopulmonary testing, the 6-minute walking distance, so the muscle strength, the laboratories, BMP, hemoglobin levels, serum natrium, albumin levels, or kidney functions. From echocardiology, the LVEF and dilatation functions are collected. Other factors we just are watching about the SAS syndrome. So those are the known prognostic parameters. So statistical analysis, correlation analysis, the Pearson's correlation coefficients, and then multivariate regression analysis and cutoff point rock curve analysis for cutoff point. So patient characteristics. This slide shows the patient characteristics. So in this study, our patient is relatively young, and peak VO2 is good, and the BNP levels maybe lower. That means mild patients, and also estimated GFR 67 it's the same as well. So this slide shows a correlation between pH and non-prognostic markers. So pH has really good correlation with PVO2, also 6-minute walking distance. But still significant correlation with VVCO2 slope, also other hemoglobin levels, and it's a depression score of health score. So we put those factors, those parameters, into multivariate regression analysis. So it's a PVO2, selects only as an independent predictor for pH score. Then we made those rock analysis. So pH from the results, this result shows pH of 18 scores predicts 18 milliliters per kilogram for PVO2. Then pH score of 22 may predict PVO2 of 14 milliliters per kilogram per minute. It's 18 minutes is prognostic. It's a good level for longer life, just in terms of prognosis. And then 14 milliliters per kilogram per minute is only one criteria for heart transplantation. So from here, I'd like to show you our multi-central cohort study. to show to show the prognostic value of P8. So this is we call the PD-MET studies. This is a part of PD-MET studies that we physical therapists and cardiologists from 24 hospitals all over Japan collaborate this PD-MET trial, and I'm in charge of this cause study. Study design here is LGBT criteria congestive heart failure, chronic heart failure patients admitted by acute exacerbation of heart failure. And at discharge, lab data and the physical performance data, also some questionnaire life function scale is here. So P8 is a part of life function scale. I'm not saying the other part of life functioning scale. After they discharge, the 1 month, 3 months, 5 months, every 2 months, from 1 month to here, and also every 3 months up to 2 years, we send a letter to patients to confirm their healthy condition or health conditions. And if they replied as they checked as just hospitalized, and then we made a call to doctors of the hospitals to confirm their etiology or their cause for hospitalization. So 235 patients are successfully corrected from 2008 May to 2009 June, and we just complete 2-year follow-up in this month. So this is a patient characteristics baseline data set, 254 patients. So I'm probably 19 years old, and so there's many male patients, and the cause of heart failure is ischemic induced heart failure is much more greater than our previous studies. All right, so this is a result. The result is 20% of our patients manifest, have outcomes here. But probably, our result is, this is a bigger size of Japanese cohort studies. So by comparing this result, our population, patient population might be mild than usual Japanese heart failure population. So from the statistical analysis, P8 over 20 points are selected for prognosis. And this is our Kaplan-Meier survival curves. So adjusted heart rate ratio is 2.7, but still we have the higher negative predicted value, the 90%, and lower positive predicted value. That means P8 is suitable for for screening of event-free patient. But I think still, if we have more advanced heart failure patients, this positive predictive value may be increased. Okay, this is a patient characteristic of it's a good patient group, and this is a greater physical functional limitation group. So we have many difference here. So this result suggests we may be able to increase their 2 years prognosis by, increase those parameters. Probably skeletal muscle function along with hemoglobin levels or other lab data. So, well, thanks very much for attention. Okay, this is my slide.
Okay, let me then very shortly make a short summary of our session. So, ladies and gentlemen, very briefly, I think that we can summarize that exercise-based cardiac rehabilitation programs improve arterial function, especially among those patients with reduced arterial function. And resistance training connected with activities of daily living is an essential part of cardiac rehabilitation, especially on older congestive heart failure patients. Interestingly, type 2 diabetes does not modify dose-response relationship in exercise training among cardiac patients, and I'm quite sure that everyone in this room, we are same idea that we really need some simple practical measures, and we learned today that simple measure of functional limitation predicts peak aerobic fitness in patients with congestive heart failure. Finally, I want to emphasize a couple of things which we may need to think in the future, and first of them is that in this slide is very nicely seen what is really the situation if we think about the participation in cardiac rehabilitation in Europe. And I know that the United States, the numbers are quite similar, so we can conclude that at about 15 to 30% of patients, they are participating to cardiac rehab, even though we know that we can get really many benefits, as we have seen also today. Of course, we can think about what is the problem. There may be absent or inadequate legislation in some countries. We have really laws for the cardiac rehab. We have some problems with funding, maybe professional guidelines at the national level, maybe they are missing. Maybe we have some challenges in our information systems. And finally, in a very practical point of view, if you think about this promoting cardiac rehab, how we can get patients to our programs, we know that there are some barriers. Then we know that there are enablers if we have flexible program available, if there is a good interaction with healthcare providers, and if the information is given at appropriate time, it may help to attend to cardiac rehabilitation programs. Specific issues, men should be treated differently compared to women. Probably family members may not are included in education, which may affect to attend. How do these cardiac patients attend to rehab programs? And then on the left side you can see we have a lot of challenges where we have definitely a lot of work to do. Finally, on the behalf of all speakers, I want to thank you very much, Huulkompari, for supporting us and making this session possible. So my sincere thanks belong to Huur. And finally, I want to express my warmest thanks to all the speakers today. Your speaks were great. And finally, very many thanks for you, ladies and gentlemen. You make the day. Thank you very much and have a nice day.